This is a 62-year-old Hispanic male who was in his regular state of health until last night when he developed chest pain. He called EMS because he was experiencing substernal chest pain with sudden onset, non radiating, and a crushing sensation. It was a 10 out of 10 pain and was constant. Nothing relieved the pain. He's never had this pain before in the past. Associated symptoms included nausea, vomiting, dyspnea, and diaphoresis. All associated symptoms started soon after the chest pain. He did not take anything for the medication, but just called 911. EMS found ST segment elevation on arrival. While transferring patient to the stretcher, per EMS, the patient developed ventricular fibrillation and was pulseless. CPR was started and was defibrillated at 200 joules. The patient automatically retained spontaneous circulation after defibrillation. Only received 1 round of chest compressions per EMS. Aspirin 325 milligrams was given before arrival to the ER. He was taken straight to cath lab and a cardiac catheterization was performed with stenting to the LAD, which was 100% occluded. He was hypotensive in cath lab and was in cardiogenic shock. He was put on an intra-aortic balloon pump and vasopressors before coming to the ICU. He also was placed on a 50% aerosol face mask because patient did have an episode of vomiting during the cath lab procedure. And an NG tube was placed on arrival to the ICU, and dark coffee ground material was what came out. Past medical history includes hypertension, no surgical history. Both parents are deceased and both had hypertension, but the patient's unaware of cause of death. Patient is divorced and lives by himself, works in a sulfur factory. Does have family support with his 1 child. Compliant with medications, and does not follow a strict diet. Says he does use marijuana on occasions, but does not smoke or drink. Home medications include lisinopril 20 milligrams daily, amlodipine 10 milligrams daily, Lopressor 25 milligrams twice a day, and Cardura 8 milligrams daily. States he's up to date on his immunizations and will consider the flu shot with this admission. No known drug, food, or seasonal allergies. Laboratory data includes the EKG on admission revealed ST segment elevation in the anterior leads with reciprocal ST segment depression in the inferior leads. Current EKG post-cath lab procedure is atrial fibrillation. Sodium is 137, potassium 4.8, BUN 40, creatinine 2.6, GFR 22, and magnesium 2.1. AST 577, ALT 199, white blood cell count 21,000, hematocrit 36%, platelets 188,000, INR is 1.16, troponin I was greater than 50, BNP 283, and lactate 3. All other labs were unremarkable. The chest x-ray revealed initially on arrival to be clear, but a few hours later revealed bilateral pulmonary infiltrates, especially involving the upper lobes after cath lab. Review of system, the patient denies weight change, fatigue, weakness, fever, chills, or night sweats. Did have diaphoresis with chest pain, but no other abnormalities with skin prior to the chest pain. Denies murmur, palpitations, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, or edema prior to the episode of chest pain. Denies wheezing, cough, hemoptysis, pneumonia, asthma, or bronchitis. Denies any abdominal pain, indigestion, changes in bowel movements, changes in appetite. He did have an episode of nausea and vomiting with the chest pain, but prior to this did not have any episodes of nausea or vomiting. He denies muscle weakness or pain, denies any changes in physical activity. On assessment, the patient just came back from cath lab and is in the supine position with an intra-aortic balloon pump in place to the right groin. He's a 62-year-old Hispanic male who is well-groomed and answers questions appropriately. He is in critical condition and was placed on an aerosol face mask for respiratory difficulties. He does converse and answers questions appropriately. Blood pressure is 80/40. Heart rate is atrial fibrillation at 115. Temperature 37.3 degrees Celsius. Saturation is 92% on a 50% aerosol face mask. Respiration is 25. He's 5 feet 4 inches and weighs 150 pounds. He does have cool extremities with capillary refill greater than 33 seconds. Atrial fibrillation, irregular rhythm. No murmurs, rubs, gallops, clicks, or precordial movement. Thready, faint, palpable pulses on bilateral upper and lower extremities. JVD present. The intra-aortic balloon pump in place at 1:1. Equal expansion on inspiration and exhalation. No use of accessory muscles. He is taking shallow breaths and is tachypnic. Diminished breath sounds heard throughout. bilateral inspiratory crackles, and rhonchi. Abdomen rounded and soft, no scars or masses, active bowel tones, no pain on palpation, NG tube in place with coffee ground output. Fully in place with yellow urine, at least 40 cc's an hour. Patient is lying flat because of the intra-aortic balloon pump. He's able to move all extremities. He's oriented times 3. No neurological deficits and does follow commands. The patient's main problem was the chest pain, which could be due to an MI, a dissecting aortic aneurysm, pericarditis, and a variety of other diagnoses such as pneumonia, PE, or esophageal disease. MI is most likely because was confirmed through cath lab because of the 100% included LAD. In summary, this patient's main problem started with the acute ST segment MI. He also went into cardiogenic shock post-procedure as evidenced by hypotension, cool extremity, increased liver enzymes, increased BUN creatinine, positive JVD, and increased lactate. Also is in acute respiratory failure secondary to aspiration pneumonia and also cardiogenic pulmonary edema as evidenced by the symptoms and chest x-ray. The patient also vomited during the procedure which resulted in the aspiration pneumonia. Does have a possible acute GI bleed as evidence of the coffee ground emesis from the NG tube. Does have probable acute on chronic kidney injury as evidence of BUN and creatinine elevation and decreased GFR. This acute event is secondary to cardiogenic shock and hypotension. But because of the patient's history of hypertension, does probably have chronic kidney disease also. Elevated liver enzymes, most likely shock liver, most likely from cardiogenic shock and hypotension. Also with leukocytosis, secondary from MI and aspiration pneumonia, and also has hypomagnesemia. Plan is to continue care and management of the patient in the ICU. Will check a stat arterial blood gas and check as needed. Start on nebulized albuterol and Atrovent every 4 hours and as needed for respiratory distress. For increased respiratory distress, we'll consider BiPAP and may also need to require intubation. Start the patient on intravenous Solu-Medrol for aspiration pneumonia. Patient started on Zosyn 3.375 every 6 hours for broad spectrum coverage. GI doctor to do EGD on patient. Currently not on any blood thinners such as heparin or Lovenox and no antiplatelets such as Plavix. Will wait till after the EGD. Currently on Protonix IV 40 milligrams twice a day. Pending nephrology consult for acute on chronic renal failure. We'll start normal saline at 125 cc's an hour. We'll monitor fluid status with blood pressure, urine output, and respiratory status. We'll titrate Levophed for SBP greater than 100 and MAP greater than 65. Currently in atrial fibrillation. He's on amiodarone. We'll defer to cardiology for all cardiac-related issues. He's on the intra-aortic balloon pump at 1:1. We'll obtain follow-up blood work and chest x-ray in the morning, and we'll follow the patient closely in the ICU. Key points to this case study is that this patient has a multitude of problems along with the MI. First, this patient has a probable GI bleed. Does need to be on heparin because of the stent and the intra-aortic balloon pump, but because of the GI bleed, unable to anticoagulate until after the EGD results. Second, this patient is in respiratory failure, not only because of the aspiration pneumonia, but also because of the cardiogenic pulmonary edema from cardiogenic shock. This respiratory distress is multifactorial. Third, this patient was started on broad-spectrum antibiotics for aspiration pneumonia and also started on Solu-Medrol for their aspiration pneumonia. Fourth, the patient does have an elevated BUN creatinine and is in an acute situation, but because of the GFR and the patient's history of hypertension, most likely has a chronic component to this acute kidney injury. Next, cardiogenic shock is diagnosed by clinical signs and hemodynamic parameters. This patient had hypotension, cool extremities. He also had a systolic blood pressure of less than 90. Finally, the EMS system saved time in this patient's situation and identified an acute MI in the field, which saved the patient time, and the patient went straight to cath lab on arrival to the ER.